So this slideshow intends to build on the basics. Hopefully you've watched that slideshow already. Let's talk about some application stuff. So Jimmy Meligrito is a 24-year-old man. He is a third-year nursing student. He's working 20 hours a week on top of his nursing studies as a campus security guard. He's working 8 to 12, 8 p.m. to midnight, 5 days a week. Living with his dad, who's also a student. Neither one of them likes to cook. Jimmy was diagnosed with type 1 diabetes 12 years ago when he was 12 and has been dealing with it since. Right now, he's doing 10 of Lantus and 6 of Lispro in the morning with breakfast. Lunch and dinner he covers by carbs. And I would encourage you to read about how that is done and counting carbs and then deciding how many units of insulin to cover by the carbs. And then he does another 20 of Lantus in the evening. Checks a finger stick blood sugar 3 or 4 times a week. Not great at this. He really should be doing this more, but he's too busy. You know, he's got all his nursing studies. He's just, unfortunately, when we're studying, we often don't do the things we're learning to tell people how to do. So he's too busy for exercise. He's got his clinicals. He is doing some weekend sports. Hasn't seen his provider in almost a year. You'd be surprised how often this is the case. Diabetics are supposed to come in every 3 months for an A1C check, but unfortunately, they don't always. What do we need to know to take care of Jim? We need to understand what diabetes is. We need to understand the pharmacology of his 2 types of insulin. And then there's some other stuff that we need to know. So let's talk about it. So what does diabetes mean? Diabetes is actually a word that means production of too much urine. People with diabetes put up too much urine because they get too much sugar. So the sugar makes them thirsty. They create more thirst. They drink more. They have more fluids. Therefore, they have more to pee out. Diabetes insipidus is another form of diabetes which has nothing to do with sugar. It basically is lack of antidiuretic hormone, and those people will put out 30, 40, 50 liters of urine a day and will become dehydrated oftentimes. And so we call those things when somebody has too much urine production, we call that polyuria. And when you have too much thirst, we call that polydipsia. What causes the high blood sugar? Well, lack of insulin. He just doesn't have enough insulin because he's a type 1 diabetic. And so we talked about in the last presentation the different types. You know, most of those are actually not used, but the fast and the long acting are the ones that we use mostly. And again, the super fast, the quick acting, those are the ones that are in pumps. And we can use the older versions. There's several of these that are available at Walmart for a little cost. And unfortunately, we have had to go backwards, and we now do this. One of the things to remember is to, when you're drawing up insulin and you're mixing insulin, if you're mixing regular and NPH, you inject the cloudy, you inject the clear, you draw up the clear, and you draw up the cloudy. And that means you draw up the regular before the NPH, RN, regular, NPH, because you want to be an RN. Again, it's sort of an archaic skill, but it is sometimes still used. Other issues with Jim, he's stressed, he's not getting enough exercise, his diet is not great, he's eating too many carbs. Does he not know enough about this? Maybe not, but on the other hand, it's also possible that he knows and really cannot actualize these behaviors because of all the other stresses in his life. He knows what the short-term complications are as far as vision changes, as far as confusion, as far as all of those kinds of things. The long-term complications we know are really related to vascular, renal, and optic issues. Sexuality issues are probably not paid attention to enough. A fair number of the patients that I have that have erectile dysfunction have diabetes, and they have not taken care of their diabetes well enough. And so a lot of these folks don't necessarily connect that. They figure, oh, you know, I'll run an A1C of 10 or 11, no big deal. And then when they start to have erectile issues, all of a sudden they pay attention to it. People that have diabetes have a higher risk for infection because they got more sugar hanging around, and bacteria love sugar. So Jim's in clinical. He's urinating frequently. He's thirsty. His vision is blurred. He's tired. He had a couple of beers last night, and he only got 4 hours of sleep. And he also forgot his insulin this morning. Well, Jim, what's going on? By noontime, he's at a clinical, and he's starting to have abdominal pain. He's feeling weak. He's having a rapid pulse, and he actually vomits. These are all signs of diabetic ketoacidosis. So they took him down to the ER. His fasting blood sugar was 300. Weirdly, the normal arterial pH is 7.35 to 7.45. He's actually 7.1. So he is acidotic. He's not producing enough insulin, and therefore he has gone into a ketosis. So we give him an IV with normal saline with a little bit of potassium. Unfortunately, what happens is the potassium all leaves the cells. The serum potassium will be normal, but the total body potassium is low. So you give him some insulin, you give him some normal saline, you give him some potassium, and within a matter of an hour or two, most of these people are going to be feeling a whole lot better. So 3 hours later, his blood sugar is down to 160, his pulse and his blood pressure are normal, and then we're going to have him follow up with the diabetes educator. The thing with that is that he probably is not that much of a knowledge deficit, but the diabetes educator are often good people that'll check in, they remind, and they're a good support for diabetics. Unfortunately, a lot of hospitals are cutting that position because there's not good reimbursement for it. But it is something that is very helpful. So he doesn't. So what happened to Jimmy? He didn't have any insulin. There was lots of demand for the insulin with all the stress, everything that was going on. When he was urinating more, he peed out more potassium. It came out of the cells. The cells shrunk down even more. They were already shrunk down from a high blood sugar. And that's why he got the cognitive and other symptoms that he got. So people that have the other kind of hyperglycemia, which is hyperglycemic non-ketotic coma or syndrome, they will have signs of dehydration. They'll be peeing out excess sugar. But the difference between them and someone with DKA is that they do not ever go into a ketosis. They don't go into an anaerobic metabolism, so they don't develop those other symptoms. So they will develop these dehydration signs such as thirst, soft eyeballs. We talk about that, but to be honest with you, I've never really checked, and I don't think it's anything that's that critical in physical exam. But they'll be weak, they'll have a rapid pulse, they'll have a low blood pressure. And the other things that people with ketosis get is obviously high hydrogen ions, which give you a low pH, which is counterintuitive, I know, but just something you got to memorize. And so we call that diabetic ketoacidosis, or DKA. And so by trying to compensate for that low pH, he's going to breathe fast. And so he has very fast respirations, which someone with hyperosmolar issues will not. We call those Kussmaul's respirations, when someone is breathing so fast. And so when someone has Kussmaul's, that is often a good sign of acidosis, and especially if you've got somebody that's diabetic and they have a little bit of a fruitiness to their breath, they'll develop this ketoacidosis. Interestingly, this almost smells a little bit like a hangover breath, And unfortunately, sometimes people that have DKA are brought into the emergency room thinking that they're having a hangover. And fortunately, paramedics do check blood sugars way more than they ever used to. And most of these people, they will have popped them out in the field, and they will have found that they are hyperglycemic, and then found out that they were diabetic. And again, they'll have more decreased level of consciousness. I've seen somebody with a hyperosmolar non-ketotic syndrome that was a type 2 diabetic that's had a blood sugar of over 1,000 and still been walking and talking. So the DKA people really get decreased level of consciousness and way more nausea and vomiting than the other folks do. So if you have somebody with DKA, what do you need to do? You need to treat their dehydration, you need to treat their hypoglycemia, and you need to treat their acidosis. And if he had taken too much insulin, he would have had a hypoglycemia issue. And when people have hypoglycemia, they get pale, they get sweaty, they get cool, they'll get anxious, they'll get hungry, they'll sometimes feel fatigued, headache, mood changes. Some people get seizures with hypoglycemia. And obviously, you give them sugar. If they're awake enough, they just take in some sugar. They drink some orange juice, they drink a soda, they drink something. It's best to check a sugar first if you can, just because sometimes people, oh, I feel lousy, I'm going to take orange juice. You feel lousy because you feel lousy. Your sugar's fine. So it is always better to check that. But that is often the issue when someone feels hangry or not good. So long-term complications of type 2 diabetes, also with type 2. This says type 1, which is what I'm focusing on, but also type 2 will get these, but it takes them longer. So problems with kidneys, nephropathy, retinopathy in the eyes, neuropathy in the nerves, especially in the feet. Lots of times these people have numb, tingly feet. They'll often have had A1Cs that are very high for a very long time. And you also can get that neuropathy in your stomach. You can get a gastroparesis in which your stomach doesn't empty well. So a lot of those people have nausea, lots of different things. One of the other things that a lot of people don't think about is that you'll get a neuropathy of the heart, actually, in which you get a decreased response to chest pain. And so silent heart attacks are surprisingly common in diabetes. Microvasculature also is impaired. People start developing little tiny clots, not big enough to cause major problems, but enough to decrease circulation. And diabetics that are poorly controlled sometimes end up with amputations. So what do? If somebody's got nephropathy, we got to check a lab, BUN creatinine clearance. Protein may leak into the urine, and that's why we check microalbumins on diabetics at least once a year. There's some exceptions to that, but the point is still the same. How would we recognize a retinopathy? Well, they really have to have an eye exam. And generally, this needs to be a dilated eye exam by an eye doctor. There is some benefit if you catch it early with laser, but it's always better to catch it before it happens and prevent it. Neuropathy, as we say, the feet has lots of issues. We use the Carville filament, which is a way to check for sensation. So let's go on to Leroy. Leroy is a type 2 diabetic, and he has been for the past 10 years. He's African American. Fair number of African Americans do get diabetes. He is 6 foot tall and 285 pounds. I'll let you compute his BMI. You can easily do that with a BMI calculator online, but you can see that he is obese. He drives a truck, so therefore he needs a DOT certification. And he's on 3 medicines, Micronase, which is glipizide, Metformin, Avandia, which is an older version of pioglitazone, and acarbose. Blood sugar is still 230. Well, what should we do? Well, with some people, we'd add basal insulin. Well, the problem with that here is that we can't because he needs DOT. So we do have some other options now. if it's 1990, these are really the only options we have. But here in 2019, we have the GLP-1 medicines, we have the DPP-4 medicines, and we have the SGLT2 medicines. And so we really would try to get him on a GLP-1. The DPPs, as we know, do not have the same level of efficacy, although we might be able to get him down in the low 100s with a DPP-4. The SGLT2s also have good benefit. There is some association with vaginal and what we call balanoposthitis. If you have a man that has not been circumcised, he can also get a yeast infection under his foreskin. Men that are circumcised rarely get any sort of yeast infection in their groin. But that's obviously an issue with an SGLT2 because you got so much sugar coming out there. It's almost like women that are diabetic that build up a lot of sugar in their vaginal area. So what should Leroy weigh? Well, I said I was going to let you compute the BMI. I get 39. He should be at least 27 or less. And so either way, he is overweight and technically obese. Anything over 35 is class 2 obese. Anything over 40 is morbidly obese or class 3 obese. The thing is that you have to remember that BMI is a blunt instrument. There are people that are bodybuilders who have high BMIs because they have high weight. So the next thing to check after BMI is basically just look at the person and also maybe ask them their waist size. If you've got somebody with a BMI of 39 but their waist size is 38, they're not obese. So type 2, we said the beta cells are still producing some insulin, but not enough. And the cells are resistant. They don't get DKA, but they do get this hyperosmolar, hyperglycemic, non-ketotic syndrome or state. Some refer to it as HHNK, some refer to it as HHS. There's a bunch of different abbreviations, but the point is it's not DKA. So they don't have the fast respirations, they don't have the fruity odor to the breath, and they don't have the nausea and vomiting. So again, going back, just to talk about oral therapies in regards to how they work. The ones that try to get more insulin into the cell are the hypoglycemics. They increase insulin secretion. The glitazones decrease resistance. The gut enzymes blockers and the biguanides try to lower the blood sugar with other mechanisms. The hypoglycemics basically squeeze the pancreas and try to get it to secrete. The meglitinides are much more expensive, but are good if you have somebody that's allergic to sulfa. They have a very long half-life. So if you have somebody that gets hypoglycemia, the problem is you can't just give them some orange juice because a half an hour later the orange juice will be gone, but the glipizide or the glyburide or whatever the oral hypoglycemic is not going to be gone. So that's a great challenge with those medicines. They can affect the liver or kidneys. It's not that common, but something to keep in mind. The biguanides, as we say, there's little risk of hypoglycemia. We've talked about metformin a lot. I do think it's a great medicine. Rosiglitazone is Vandia. We don't use that one as much anymore. We're using pioglitazone more. Resulin was actually taken off the market due to liver problems. All of the glitazones work the same, but don't necessarily have the same side effects. Metformins, we really should not give it with anybody with a creatinine above 1.4. We're now changing that to the GFR or creatinine clearance. And so generally you need to look that up and just make sure that they don't have impaired kidney function. We used to stop them 48 hours before the use of contrast dyes. We do sometimes still do that. More often than not, we'll actually just stop them after the use of contrast dyes. So if you have someone that goes and has a CT scan with contrast, more often than not, they'll have them stop their metformin for a couple of days after. People on metformin should stay well hydrated, as should everyone. The gut enzyme blockers, gas, we don't use them much. How do we know what the blood sugar was? We know the A1C is a great test. It actually gives us a mean blood glucose over the past 3 months or so. And so we usually refer to it by the actual grams of the A1C. And then you can actually look up a chart online that'll give you a mean glucose. So 8.0 calculates to a mean glucose of 266. Diabetes affects sexuality. Clearly, vascular changes, right? You know, the vasculature to both the penis and the vaginal area, including the clitoris, are very related to how well the circulation is getting there. If the circulation isn't getting there, people stop feeling sexual. And so for some people, this is a big issue. For some people, they really don't care. But ways to treat this, clearly we try to keep their diabetes under control. The other medicines, such as sildenafil, are an option. We've tried those in the women, haven't had great luck with them. So there really is not a lot of medicines that we can use for impaired sexual desire in females. Some of the hormones, lots of different options, but we'll talk about that when we get to women's health. So just to summarize, patho, short-term, sugar, dehydration, acidosis, long-term nerves, blood vessels, and the pharmacology of diabetes. We try to have them do home glucose monitoring, and we frequently use them in combination therapies. Fructosamine actually gives you 2 to 3 weeks of average blood sugar. We don't use that much. We almost always use the A1C. And so drugs of the week, I'm actually going to probably alter these, and I will post a different list on the discussion board on Blackboard. Thanks for listening.